Hello, very good evening to all. We Urgo Medical India is very excited to welcome all of you to the launch event. Yes, today we are proud launching the only silver dressing with a complete and continuous cleaning action with a multiple level of evidence. That is our UrgoClean AG. Today we have our eminent speakers who shared UrgoClean AG in a real life situation. So they will be sharing their experience. I welcome all the speakers to the panel, and also I would like to welcome all the participants. I'm handovering the session to Pratik to share our ambition in India.
Thank you, Ashwati, and thank you, Said, for unmuting me just in time. Uh, I think in an ideal world, and this is definitely not the year of the ideal world, we would have liked to be somewhere with this view in Mumbai, presenting the cases by doctors done in Mumbai and Nashik in this very nice forum where we seem to have a lot of participants. But since that is not possible, let us be happy with what we can do digitally today, share it across over. And definitely in the future, I hope that we can all assemble together at a nice location somewhere and have a great discussion of feedback of many more clinical cases of our highly evidence-driven products. So what I would just like to do quickly is before we start going to the main agenda of the clinical cases, I really want to tell all the participants, tell all the respected doctors, what is our mission in India? Who is Urgo Medical India? So I think many of you must have known our company from before. Urgo Medical India formerly used to be known as UCare Pharmaceuticals, the collagen people, and we have many brands still active very strongly in the market like K Collagen and Biofill, which I believe many of you must have used in advanced wound care practices. Then a change came in 2016. In 2016, UCare did a joint venture with Urgo, a French multinational company, and together started promoting products from both Urgo and UCare range manufactured in India, manufactured in France, to meet the needs of clinicians and patients all over India. And then in 2019 came a very big change as well when UCare became a part of Urgo Group, and now we are transitioning our identity to Urgo Medical India. So we have an evolution. Our corporate history has started from a local organization to becoming part of a large global organization. But then that is just a corporate history in terms of timeline and chronology. What I really want to tell today is who is Urgo Medical India? Who are we as people? Who are we as an organization? What are our values and our missions? So our claim is healing people. And that those are exactly our missions. Our mission number one is healing people suffering from wounds. Like we always like to say in Urgo, we don't treat a wound, we treat a patient suffering from a wound. And that is exactly what our studies, what our resources, our investments are into, to develop patient-centric products. Our second mission is to make a difference by helping healthcare professionals heal patients. So we don't only want to push you some products, but we also would like to do impactful programs, impactful pathways with you, where you can really heal your patients, especially in chronic wounds that requires care over a period of time. And we go about achieving these missions through three main pillars. The first pillar is that we put patients at the heart of everything. We really want to drive patient-centric solutions and go beyond just the treatment on that day to give an overall better patient experience and a patient journey. The second mission, the second part how we achieve our mission is caring for caregivers. All over the world, where Urgo is present since many years, especially in Europe, we have strong partnerships with healthcare professionals and scientific bodies. And we also have extensive educational programs to support healthcare professionals. And in Asia Pacific, my colleague Emilio, who will be talking later today, is driving Education and Training Alliance as well. And the third main pillar for us is leading with science. We strongly believe in investing in R&D, in clinical evidence, so that the HCPs who are using our products in wound care feel confident that they are giving the best possible treatment that is evidence-driven to their patients. And that is really very strong statement for us, an important part of our values. And we don't want to just put nice sentences on a slide. We really want to show some action on it. And which is why I want to say that when we say we are putting patients at the heart, we really want to walk the talk. And recently we have launched on 13th of November, a diabetic foot ulcer awareness campaign, Save Feet, Save Lives. This is really critical in India. Every 20 seconds, a limb is lost somewhere in the world as a result of diabetes. And especially in India, diabetes has evolved into some sort of a pandemic. We have 700 lakh plus diabetic patients, and nearly 1/4 of them today are at risk of developing a diabetic foot ulcer. That makes it even more critical, which is why we have launched this campaign, Save Feet, Save Lives. And I would really invite and urge all the participants to visit our newly launched website, savefeetsavelivesIn, On this website, you can find some material for patient education as well as encouraging an early referral pathway through general practitioners. So that exactly is the objectives of this campaign, that we want to aim for early identification, appropriate referral and education of both patients and non-specialist healthcare professionals in diabetic foot ulceration. This campaign has been rolled out globally. In fact, SafeItSellers.in is the Indian version of the campaign, but we actually have done it in many other countries and have received the endorsement for this campaign from recognized global bodies and scientific associations. So we really look forward to rolling this initiative out soon in India, along with all of you, along with all your associations. The second thing I want to say is leading with science. Once again, I would say we walk the talk. We really believe in proving the efficacy of our product with the highest level of clinical evidence. We have had 80 plus clinical trials and observational studies done on our products. More than 65,000 patients have been included in these many studies, which include lots of RCTs and observational studies. And last but not the least, we have an endorsement. We have endorsement from the most recognized journals of the world. Very recently, we got a publication in the Journal of Wound Care about the dressing that we are going to talk later today, UrgoClean AG, on more than 2,000 patients, which showed really encouraging results in the observational study. A few years back, we got a very strong recognition in the Lancet Journal of Diabetes and Endocrinology for diabetic foot ulcers with another product that we are going to launch soon. And in fact, that was the first time that the Lancet Journal published a wound care study. That was the level of evidence, the level of impact that the study had. So that is really why we are very proud to bring evidence-driven solutions, and that would be our mission going ahead in India. We already have offerings in India, so it's not like before this we didn't launch anything in India. I believe that you will be familiar with the brands such as Biofill and Collagen since many years that were already launched in the market by UCare. Furthermore, over the last couple of years, you must have also seen and hopefully used UrgoTool and UrgoTool AG, which are based on the technology TLC and TLC AG. TLC is really the base, the heart of our dressings. It allows automatic removal. It allows moist wound healing environment. So I hope you have all had a great experience with TLC. And now that we are at a crux where chronic wound care is becoming such an important priority in India, we want to take our TLC technology to the next level, which is why we are launching new products with TLC at its core. This is our pipeline of products. This year we are launching, in the process of launching UrgoClean AG, and we are going to see more of that later today. Which is TLC AG plus polyacrylate fibers, which offer complete and continuous cleaning action and antimicrobial action. And soon in 2021, we are going to bring UrgoStart, which is TLC NOSF technology. It's a sucrose octasulfate dressing, and it has been proven at every level of pyramid of evidence, including recommendation from the NICE guidelines in the UK and the global IWGDF guidelines. So we cannot wait to bring these solutions to you so that you can use it to treat your patients and to give them better outcomes. With that, I will end speaking about who we are and go more to today's particular event. So once again, I thank Dr. Jessy, Dr. Venkateshwaran, and Dr. Arsule, who have agreed to present their feedback to us, very candid feedback. And I will hand over to the moderator for today, who is my colleague, my dear colleague, Emilio Gallia, who is the International Medical Director of Urgo Medical Asia, Pacific, and Middle East. Emilio has a MSc in Skin Integrity and has 20 years plus practice in wound care. And quite important to say that he is the director of our Education and Training Alliance. So he's working in conjunction with SCPs in many countries for developing impactful training and education programs. So over to you, Emilio.
Thank you very much. You allow me just 1 second. Thank you very much, Pratik. Thank you very much, Ashwati. Thank you very much for all the whole Urgo Medical team from India. Thanks for the hard work you are doing. Thank you very much for all the attendees and panelists this afternoon. We would like to give our heartfelt thanks to you, especially in these very difficult times, for the amount of good work you do with our patients. I hope that you will be blessed with all what you need because of all these difficult situations that you are facing. So going on to the subject of today, Aswati already mentioned about that this is a silver dressing, but it is a unique silver dressing. It's not like other silver dressings that we are accustomed to and have been accustomed to for the past 20 plus years. What we know and definitely know is that no wound, especially chronic wounds, are free from infection all the time. they are all prone to infection, especially when we have patients with related comorbidities or patients who unfortunately delay being seen by a specialist like yourselves. And one of the big problems that we are facing today is biofilm. We haven't been talking for biofilm in wounds for many, many years. It's been something which is relatively recent that we realized that one of the huge problems with wounds, with chronic wounds, is biofilm. So we need to find solutions how to remove this biofilm. And in chronic wounds, there is this vicious cycle that is happening, but sometimes even we find it in hard-to-heal acute wounds or stalled acute wounds, where we have these free-floating planktonic microorganisms that start forming into a biofilm. The result of these issues will give us an increased slough. The slough itself is favorable for the microbial growth. That on itself will increase the exudate. The exudate itself enhances sustainability of the biofilm, and that goes on and on. So basically what we need to do is find something that is a good antimicrobial, but has also a completely cleaning action so that we continue to manage the wound even while the dressing is in place. So I'm sure all of you know what a biofilm is, but just as a reminder that the EPS is there as an umbrella that doesn't allow any antimicrobials or antibiotics to go through to the microorganism, and therefore it's like a cocoon keeping the microorganisms intact. And the problem with the biofilm is that many times it's hard to detect. We don't uh, we don't manage to visualize it every single time. It's only very, very advanced biofilm that we visualize. And there are only very few tests that we can do on the wound to show us that the wound has biofilm. However, what we know is that the vast majority of chronic wounds will have a biofilm, and the stalled wounds in the acute wound area will also have biofilms. So if we look at what is happening from planktonic bacteria to mature biofilm, what is very important to note is that the microcolonies start forming around 6 to 12 hours. Why is this very important? Because if we do manual mechanical debridement or surgical debridement, we stand a good chance that the biofilms will start forming again. So basically, we either do a dressing change with mechanical manual debridement twice a day, or else we have to find a solution that will do that to us. So how to treat the biofilm is that, as we said, we have to remove the biofilm by means of a mechanical action to remove that cover of EPS, then use in conjunction an antimicrobial, something like silver, that would be able to kill the microorganisms inside. Keeping the wound clean is necessary. We cannot heal the wound if we have that vicious cycle that we talked about. So we have this happening all the time, the components of the inflammatory response, the inflammatory system that is keeping on responding. And this triggers other things like metalloproteinases that keeps on degrading the wound bed. And what that happens is that we have the stimulation of signs and symptoms. And one of the things that really annoys all clinicians, but even the patients, is the amount of exudate coming from the wound. And many times when we look at addressing, one of the first things that we start asking is, but how much exudate does it take? That can be valid. However, I compare that to having a leak in the roof and just painting over it. What will happen is I'll go to bed tomorrow morning. When I wake up, the leak was coming again because I treated the signs and symptoms. I didn't treat the source. I didn't treat the source of the leak. And it's the same thing with the wounds. If we don't treat the source of the exudate, which is the biofilm and the inflammatory process, we will not manage to decrease the exudate. So rather than wicking up the exudate and continuing to mop it up all the time, we have to find a solution how to remove that. What we are trying to show you today, and what we will show you through our clinical evidence, is that this new dressing, the polyacrylate fibers with TLC technology and AG, is an effective antimicrobial and antibiofilm, but it also continuously cleans the wound. So through these three modes of actions, cleaning, antibiofilm, antimicrobial, it will start propelling the wound towards healing. The TLC layer at the top of the dressing is also going to help you with the atraumatic removal, but very, very importantly, from previous studies, we know that the TLC technology enhances the fibroblast proliferation, so it will help you heal the wounds even till the end. So the technology, what we have talking about is the TLC technology that has been proven over and over again when we did the studies with UrgoTool AG. We know it has a fast action. It starts within 30 minutes and continues with the process for 7 days when necessary. It is very broad spectrum and will reduce the healing process. And this is a snippet from the in vitro studies where we show that there's a lot of strains that are killed. It's not only just bacteria, but we have also fungi that have been removed by means of the TLCAG. So it's very important to have a broad spectrum because sometimes we don't need to target specific microorganisms, but if we have a broad spectrum, we are sure that we will maintain the action of antimicrobial on a lot of them. And although this looks like a very marketing slide, from a clinical perspective, it's actually a very realistic. On the right-hand side, you see the image of a magnet. And why do we put it there? Because there was an in vitro study of somebody who wanted to exactly know how the polyacrylate fibers work. And what they found out is that between the dressing and this slough, there is a negative and positive reaction, which actually attracts the slough to the dressing. So when you are removing it, you don't pull off the slough from the wound bed. The slough is already on the dressing. This is what makes it work on the biofilm, because the EPS is part of that slough, and the EPS will be lifted off and it will continue to clean all the way through until you change the dressing. So, as you see in this picture, the slough from the first dressing change attaches itself to the dressing, which means it's removing the slough, it's removing the microorganisms, it's removing, more importantly, that EPS. And this is an example of a small RCT that was carried out on 37 patients from 17 different centers. What is very important for me is the visuals. So there you see on the left-hand side, as you will see from cases from our esteemed faculty this evening, the amount of cleaning that happens. More importantly, we have on the right-hand side the graph that answers that expectation that we need to reduce exudate, which is for us is very important because we know that exudate is one of the biggest signs and symptoms that something is going wrong in our wounds. As we said, the second one is the antibiofilm. So how does that antibiofilm happen? You have the continuous cleaning, you have the removal of the EPS. Once the EPS is lifted, then the antimicrobial can go in and remove those microbes. these are some of the in vitros. I am not going to bore you to death with all the in vitro studies that have been done, but this was quite an important one that was published on the Journal of Wound Care, where it shows effectively how much of the biofilm is destructed immediately after the first day, and as a sustained release, as a sustained mechanical action for 7 days, which is achieved by the polyacrylate fibers, but also the killing of the microorganisms within by means of the AG. So we know it reduces the biofilm, and we know that within 24 hours up to 7 days, it can be effective. Are we telling you to keep the dressing on for 7 days? In reality, we usually don't, especially in the beginning when the wound is exudating a lot and there's a high level of infection. We probably would change it even daily in the beginning. But as we'll see, even from the clinicians presenting the cases to you, even 3-4 days is a good way how to do it. We always try to link ourselves with the best products out there, and one of the products that we know has a huge evidence against antibiofilm is a hydrofiber AG plus extra, which is basically two hydrofiber dressings attached to each other, which has silver in it, but it also has a chemical element called ETTA. So this dressing basically removes the biofilm by means of a chemical action. The polyacrylate fibers with AG from Urgo, which is the UrgoClean AG, removes it by means of a safe mechanical action. We're not putting any chemicals in there. And when we compared to the other dressing, which is the hydrofiber, we found that it is a lot stronger, a lot more efficient when it comes to the most common type of biofilms that we find in chronic wounds. In vitro studies, lab studies, RCTs, it's all very well and good, but how does it help us in our daily practice? And this is exactly the question that Dr. Joachim Dismont from Germany wanted to ask. So he got a group of clinicians who did this quite amazingly huge observational study of over 2,000 patients, which what was interesting in this study is they literally treated every wound that they saw. It wasn't specific. This was a non-interventional study. They didn't have any inclusion and exclusion criteria. So basically, they had chronic wounds, acute wounds, and all the types of wounds that they were seeing. So it's interesting to see the results, because these wounds were either very infected or less infected or sloughy or granulating. It's like what we see normally if we are in a clinic for a few weeks seeing the patients. And long story short, going to the results, we're not going to go through the whole methodology of what they did. But what we are seeing here is that in all the types of wounds, we had a huge reduction of infections and the huge reductions in the signs of the local infection within a few days. But the more it went up to the third week, the more you see the results showing there to you, reducing drastically. And again, talking about exudate and how much exudate does the dressing retain, we don't retain the exudate, we take care of the exudate and we reduce it, and we see a huge reduction to up to 70% reduction in exudate in all the types of wounds that were included here. Again, here showing us that the dressing is not there just to remove the infection and the biofilm. It also propels and helps the wound heal. If you look at the graphs that you see there, obviously, especially in the acute wounds, it worked more because there is less damage. But most of the wounds, up to 90% of the wounds, demonstrated a huge improvement, with quite a few wounds actually healing within the 3 weeks of observation. And again, here we have a look at the difference at the wound bed. So if the wound was sloughy or the wound was granulating, obviously the granulating stage, you had more wounds that greatly improved or healed. However, even in the debridement stage, you had 40% that healed and almost another 40% that greatly improved. So basically, this is showing us that when even in the normal environment of a clinic where we don't change anything that we do, we just change the dressing that we are applying to our patient, we see a huge benefit for ourselves, for our facility, but obviously a huge benefit for our patients. The more we close the wound early, the less stress for the patients and the better health-related quality of life of the patients. As Pratik said, we pride ourselves with high levels of publications and papers that have been published over these few years. And we have anything from RCTs to non-comparative trials. With other dressings, we have even systemic analysis and guidelines for practice from world bodies. When it comes to the AG range, we are more looking at what is happening day to day. And what I can tell you is that what is happening in Germany, over 2,270 patients, is happening also in India with the results, very encouraging results we are seeing from all the clinicians that are trialing this dressing. So as Aswati said in the beginning, this is the only silver dressing that will give you the assurance that it will remove the biofilm. Once the biofilm is removed, it will start killing the bacteria and the microorganisms which are inside, starting to remove the sloughs, starting to remove the infection, removing the wound from the inflammatory stage, propelling it towards the healing that we all want to see for our patients. So that is all from my side. We will be taking questions and at the end of the presentations. Now it is my absolute pleasure to introduce to you three esteemed clinicians from Mumbai. The first clinician that will speak to us is Dr. Jessy Thomas, that has been working and training in the field of the diabetic foot since 1997, with many years under the tutelage of Dr. Arun Baj. Currently practicing as a diabetic foot specialist at Dr. L.H. Hospital since 2004, and she has managed more than 20,000 cases. She holds a certificate in diabetic foot care, completed advanced training in diabetic foot at Amarita Institute at Medical Sciences, Kochi. She is a member of the FSI since inception and advisory at the Innovative Healing Systems from the USA. Our second esteemed speaker is Dr. Venkateshwaran, and please excuse me if I'm not pronouncing your names correctly. I really apologize. He is the consultant plastic surgeon and director at the Wound Care Clinic at Jupiter Hospital, Mumbai, and honorary visiting consultant at KEM Hospital, Mumbai. He is an active member of APSI, the FSI, IAAPS Mumbai, ISSH, NABI, and ISRM faculty for multiple wound care nursing education programs. Last but definitely not least is Dr. Sachin Arsule, who is a diabetic foot specialist at the Nasik Diabetic Foot Center and holds a postgraduate diplomas in diabetes and thyroid, diabetic foot from Amarita Institute, and also in hyperbaric oxygen therapy from Delhi. He is holding a membership in the DF Society of India and the Hyperbaric Society of India as well. He is working on awareness campaigns of the diabetic foot infection. So without further ado, I give over to Dr. Jessy as the first speakers to walk us through some of the cases that she can share with us. Thank you very much.
Thank you, Dr. Emilio. Good evening. Thank you, Team UCare Urgo, for involving me in this show. I've selected two diabetic foot wounds, which was operated during the lockdown period, one in the 1 month of August and other in September. The first case is a relatively acute wound on which I have applied Urgo.
Excuse me, Dr. Jessy, I think you need to share your screen. We are not seeing your slides.
Sorry.
There you go.
Next. Sorry. Good evening. Can you hear me? Am I audible? Can you see me?
Yes, we can hear you, we can see you, and we can see your slides as well. Thank you very much.
Good evening once again. Thank you, Team UCare, for involving me in this show. I have selected two diabetic foot wounds here. One is an acute wound, another one relatively chronic, which was operated somewhere during the lockdown period in the month of August and September. The first case, is a 63-year-old gentleman, a known case of diabetes for more than 25 years. He has undergone renal transplant twice. That means he is on a immunosuppressive therapy. Also a known case of hypertensive on treatment. He was very regular to my OPD, but unfortunately due to lockdown for the past 1 year, is not following up regularly. He was admitted in the month of August with the left great toe wet gangrene, foul-smelling abscess involving the great toe and the plantar space, following a shoe bite which went unnoticed. And later on, he was afraid to come to the hospital because of the COVID. On vascular evaluation, which was done multiple times earlier also, he had severe vasculopathy, and also in view of his precious kidneys, he was not at all a candidate for revascularization. However, the leg was warm, and the transcutaneous oxygen pressure monitoring also showed relatively good TCPO2 readings. Probably he was on antiplatelets and hence very good collateral circulation. Of course, he had other symptoms like loss of appetite. His hemoglobin and serum creatinine were relatively within normal limit. Basically, the history was of a 1 week history of a shoe bite, which slowly patient was, of course, walking weight bearing in spite of he regularly following up in our clinics, knowing that he should offload, and turned into a gangrenous wet diabetic foot. So he was taken up for surgery on the 21st of August. He underwent a great toe amputation. You can see the wound bed, which is there is slough, there is cut end of the metatarsal, very close to the second toe. And on day 0, day 0 shows an extensive plantar ulcer, and you can see the granulation tissue with a fluffy base. Culture showed Proteus mirabilis, and he was also put on culture-specific antibiotics to begin with. This followed day 2. Yeah. The plan was to change the Urgo dressing every 3rd day. That's the system we follow in our hospital. And so the wound size was relatively the same. We used Urgo in the first 5 dressing, changing it every 3rd day. What we saw was application of the Urgo patch was very easy. In the sense it could be cut to the size of the wound and shape of the wound. The overlapping edges onto the normal skin did not cause any problem. And there was a consistent improvement in the wound with respect to disloughing action, and also was very gentle to the surrounding granulation tissue. Removal of UrgoClean also was very easy and was non-traumatic to the granulation tissue. Pain was never a factor in these patients because of the severe neuropathy. The discharge below the patch, the disloughing effect and the wound discharge exuded together, which gave an impression of a worsening of the wound nature to the relatives and the patient. But however, once we washed the wound showed the wound was getting better day by day. The peri-wound maceration was not seen in our case, but however, that's because I think patient was on the bed. The moment patient puts his leg down and there is a gravity, with such kind of copious discharge, even with the absorbent capacity of Urgo tool, you can expect some amount of peri-wound maceration. So this was the cases. This was, you can see the day 1, day 3, day 5, and next, yeah, the last slide. You can see the improvement, the desloughing effect, what we can see, and also the improvement in the color of granulation. That's what you can appreciate in the picture, and definitely it was better. This was the acute wound. The second case was a relatively chronic wound. This patient was very new to me. He was a 49-year-old gentleman, a known case of diabetes for more than 12 years, hypertensive and hypertensive on treatment. He was a very new patient, and he did not complain of any past foot problems nor consulting anyone for the foot problem, though he was regularly visiting a diabetologist. His first visit was in the month of September, in the month of July, where he came with a history of application of Ayurvedic oil followed by hot fermentation. On investigations, regular investigation, WBC was high, renal profile was within normal limit, vascular evaluation and revealed generalized atherosclerosis. He was started on antiplatelets. However, the lesion, when taken an opinion from the interventional, taken opinion was a non-angioplastable and non-bypassable lesion. He was started on antiplatelets, silastazole, and his second, third, and fourth toe were amputated because it was it was infected. Later on, a patient was after being on antiplatelets, he was also subjected to hyperbaric oxygen therapy, which improved the overall appearance of the wound in terms of vascularity. However, the digits, the first and the fifth digit was dry, demarcated gangrene, and so he was again subjected to the first and fifth toe amputation, followed by debridement. Postoperatively, he was put on culture-specific antibiotics. After rinsing the wound with silverstream, this is the picture. What you can see the first metatarsal. The debridement was very close to the metatarsal. So, you can see a thick slough which is on sitting on the dorsum. So you can see the desloughing action of the UrgoClean AG in the subsequent picture by day backwards. The first picture. Followed by, yeah. There are two more others. Yeah. So this is you can see the cut end of the metatarsal, how beautifully it is debrided the slough there. The last picture. Yeah. So the day 14, it's a beautiful desloughing effect, and you can see the color and texture of granulation tissue, which is improved within a span of 2 weeks. So this is these are the two cases which I would like to present, one an acute and a chronic. And my Take-home message regarding UrgoClean AG is it's an excellent dressing to deslock the wound. Has a very good action on the biofilm. It's a very soothing effect and very gentle effect on the surrounding granulation tissue. In dry wounds, what I mean by dry wounds are those scars which are relatively difficult to even debride with the blade and very close to the bone. This kind, and especially bed sore, heel sore, pressure sore, if they are demarcating well, UrgoClean does have a debriding action on them, and which will help in debriding those wounds. In moist wounds, wounds with excess slough and excess bacterial bioburden, the frequent change of dressing is required. That is one thing what I have noticed, as frequent as daily. And overlapping of this UrgoClean AG onto the normal skin had no adverse skin reaction which I noticed. So initially I was hesitant, but then I did not notice any kind of allergy in all the patients. Apart from these two, I have used it on a couple of more patients. All of them did very well. Thank you.
Thank you very much, Dr. Jessy. It's interesting to recognize that there is a parallelity with the German study that they used the dressing both in acute and chronic wounds and had almost the same results. And from what I've seen from your cases, I was very happy to see that in both an acute wound, which would have given you better chances for healing, even though the patient was very, very poorly sick, but also in a chronic wound, which had been there for many months, probably, where we had seen the reaction of the wound to the dressing within a couple of weeks, basically. So thank you very much for sharing these cases with us. Now I will ask Dr. Venkateshwaran, sorry for the pronunciation of your name, to present the cases to the audience. Thank you very much.
Thank you, Emilio. And I forgive you because I feel there are enough Indians who cannot pronounce my name properly, so it's okay. Am I audible, Pratik? Can you hear me?
Yes, we can hear and see you very well. You can start sharing your screen, if you don't mind. Yeah, thank you.
Yeah, so once again, I'd like to thank Urgo and the UK Urgo team for inviting me to share my, I can say, limited experience with using Urgo Heal AG, but not with just Urgo products. I've been using UK and Urgo products since quite some time now. So this product is relatively new. I've used it and found good results in a few cases, and I would like to share my experience with the participants on this program. Quickly moving on to my first case. So I sort of have termed this by myself as a post-COVID necrotizing wound. I don't know how many of you have had a similar experience, but COVID has been a disease of thrombosis of vessels. So, we have seen a number of cases where patients are presented with large-scale venous thrombosis of larger veins, as well as arterial thrombosis, presenting with acute limb ischemia and gangrene. But in this patient of mine, basically she was a 67-year-old diabetic, and she had already been afflicted by COVID and had spent a month in the hospital, in another hospital, not in Jupiter. After which she had once discharged, and at home she had noticed that she had developed swelling as well as a bleb on the foot, which sort of turned out to be like a necrotizing infection. So on the OPD basis itself, we sort of took away the surface layer of the bleb and did a very limited debridement, after which we found that there was a layer of adherent slough beneath it, just above and in between the tendon layer. So because she was very immediately post-COVID status, she was not willing for any major operation theatre procedures or even a readmission. So we had to make do with just dressings. And one important problem in this particular patient was that her peri-wound area was extremely inflamed, and her foot was extremely painful and very sensitive, and every dressing was an ordeal for her. So I can almost call this as a chronic on acute wound. Like, it was a very acute wound. Almost when I saw it, it was just post bleb stage, so just a little older than a month. And as I told you, the wound was as I already described. So initially we started using some of the usual silver gels and all those dressings that we commonly use, and found that the desloughing was not happening as required. So, and surgical debridement with sharp instruments also was not really, because of the nature of the slough, which was thin but very adherent, it was not easily coming out. So we decided to go ahead with using UrgoClean, and we saw that we saw a very good improvement with each dressing change. The amount of slough that was seen, and especially in between the tendon areas, started reducing drastically. And as you can see, even the peri-wound area has started looking less angry and less inflamed. And wound size, I would say, I did not see a great impact on the wound size per se, but even just a simple reduction of the inflammation and thickness of the edges also seemingly gives an impression that the wound is decreasing. So it is also encouraging to the patient. And as Dr. Jessy Thomas clearly mentioned and very relevantly mentioned, that it was quite gentle and very painless to the patient. Every dressing change was never really an ordeal for her. So the pain generally came down with each dressing change. The wound also started improving and granulating, and finally, after quite some time, we were completely slough free, and we could actually go ahead and graft her. So now this is the last image, is actually showing how she is right now. Present day, she is maybe after I think 6 weeks finally. She was also ready to get admitted for a small procedure, and we could lay a small split thickness graft over there, and that was the end of that particular patient's problem. So now the second case that I would like to share with you was we call it a post-amputation stump necrosis. Now this patient was a 62-year-old male, known diabetic. Again, underwent amputation for a limited amputation, what we usually do for gangrene of toes. He had already undergone a procedure for an angioplasty for improving his blood supply. So unfortunately, the blood supply did not support the skin of the stump, and he had a stump skin necrosis. Following which, after a few sessions of dressings and debridement of the eschar, there was a layer of thin adherent slough. It was quite adherent, and for the fear of exposing some underlying metatarsals or some edge of the bones, we were going a bit slow with the debridements. So again, now we had a new weapon with us. We decided to clear, the slough using UrgoClean dressings. So the cleaning agent we always use for these dressings, seemingly at least non-infected wounds, the cultures did not grow anything very specific. So we just started doing the dressings with UrgoClean, and The usual routine of changing it once in 3 days was followed. And it was I would like to say that the patient, because of whatever the reasons, constraints of travel because of COVID, was a little reluctant, but had a oriented and educated daughter whom we could teach how to do a home dressing. So you can see that, something as simple as a Urgo heel can be even taught to the patient's relatives. And she was changing the dressing on the third day. The slough gradually reduced. The peri-wound area also became healthy, and but again, because of the same reasons of the first patient, these patients also were not really willing to go ahead with a quick surgical debridement or a re-closure of the stump or any other surgical intervention. So we resorted to just continuing the dressings with UrgoClean, and as you can see, after 19 days of dressing, most of the slough had already been removed from the wound. We had more or less granulation appearing there. The edges started creeping in, and this is how the wound was appearing on the present day. The size is significantly reduced, and you can see a very small granulating wound there, which is quite encouraging for us. The third patient case which I am sharing with you today is diabetic ischemic heel necrosis. I'm sure everybody has seen their share of this kind of wounds. 65-year-old male diabetic, IHD, PVD, having a necrotic eschar on the heel. The eschar was debrided, and after debridement, this was the wound. Again, patient was not willing because of various reasons, financial and others, for either going ahead with an angioplasty or with going ahead with an amputation to get rid of this wound status. Patient had this adherent slough, again same issues, and minimal debridement could be done every time patient comes for dressing. Again, a bit painful, strangely, even though diabetic and this thing, pressure necrosis, but still patient used to have, at least complain of quite a severe amount of pain in the peri-wound areas, maybe because of borderline ischemia only. After initiating the treatment with Urgo heel, we used to clean it with sterile water and do Urgo heel dressing. So the dressing was changed every 3 to 5 days. Slough gradually started reducing, not as much as we would like, as in we had a very good success in the earlier 2 cases, but we saw a gradual reduction, and even in I can say that even in a ischemic sort of scenario, we are seeing at least some amount of granulation which seems to be coming up. And this is the scenario present date. We have not, this patient's treatment is still going on, it's not complete. So this is the third and final case that I'm sharing with you. So my impressions about Urgo heel, and as one more dressing in the armamentarium, is that it is very simple and it is very effective for both slough as well as for biofilm management. A lot of other advantages which were described by Dr. Jessy, I completely agree with, in terms of how gently it treats the bed also, as well as the peri-wound areas also. And I can just add that, maybe this is like a useful tool when operative surgical debridement or admission of the patient, especially because of some difficult times that we are going through in terms of COVID infections and things like that. If it is getting delayed or difficult, then this can be definitely a useful tool for non-surgical debridement. And as proved by our patient as well as her relatives, it can be quite user-friendly because it comes in very easily applicable manner, as well as a very simple to use methodology. It can be very easily taught to the relatives or to the patient, as well as it can be learned by them also very simply. So I thank you all for a patient hearing, and I thank the team Urgo once again to allow me to present these cases to you. Thank you.
Thank you so very much. The messages that you gave was basically what we were discussing in the beginning. That when we find difficulty in debriding, the sloughing the wound, it doesn't mean that we have a dressing now, so the surgeon is not needed anymore. The surgeon is there. It's complementary, and it's a very good tool. I like the word you use, part of our new armament, and it is. It definitely is, especially during these difficult times where it is simple enough to teach the family, and they don't need to expose themselves coming out in the community, especially because these patients don't have just a simple wound. They have a lot of comorbidities that makes them so much at risk. So thank you very much. I'm not going to attempt to mention your name again. I'm going to call you my dear doctor. But yeah, very, very interesting cases. Thank you so much. Our next speaker is Dr. Sachin Arsule. Again, apologies if I don't mention your name as should be, to share with us your very interesting cases. Thank you very much. Dr. Sachin?
Yes, good evening.
Hi, you can start sharing. Thank you. I think you are sharing your desktop, not your PowerPoint.
Yes. Can you see me?
No, we can see just your desktop.
Good evening, everybody. Myself, Dr. Sachin Arsule.
Dr.
Hey,
Sachin,
Dr. Arsule, you need to stop sharing, and now you need to once you open the presentation, you can start sharing again, directly selecting the presentation.
Hello.
yeah, this is not your PowerPoint, doctor. I think you need to share when you open the share screen. Just click on your PowerPoint.
After the PowerPoint is open, start sharing the screen.
Yeah.
So,
There you
Perfect.
go.
Perfect.
Good evening. Myself, Dr. Sachin Arsule. Let me thank Urgo Medical team for inviting me for this session and allowing me for presenting my cases regarding the UrgoClean uses. I have 3 cases to present. Though I have limited experience with the UrgoClean, but whatever cases I have done, I have found that it is very helpful to my patients. Let us see with the first case. This is my first case where UrgoClean was used. It's a 66-year-old male patient underwent amputation followed by non-healing wound with a secondary infection since 25 days. This guy had a callus at the great toe, which got secondarily infected, followed by amputation of the great toe was done, but the wound was secondarily infected, and the wound was not healing. Vascularity was assessed, and which was showing a peripheral vascular disease, moderate degree, and the vascularity was near about biphasic to monophasic. This guy, when referred to us, as usual, I did the debridement. Then we started the UrgoClean. So 25 days old infected wound appeared with a slough. It was heavily slough, foul smelling discharge from the wound. Pain score was 4 to 6 with a heavy exudate, and peri-wound maceration was seen. The wound was earlier treated with betadine and cotton gauze absorbent dressing. Ideally, it should not be used, but when we did the debridement and we sent a tissue for culture sensitivity, and After culture report, we started the same current antibiotic also. So treatment initiation was done with normal saline clean wash and the UrgoClean AG. So we found on day 3, it's a very good improvement at the part of the wound. At the initial, I was not ready to accept, because we being the podiatric or diabetic food specialist, we do clean the wound every day or alternate day. But as the Urgo medical team, they suggested me to open the wound after 3 days, which initially I found that whether it is possible or not, because the wounds are usually exudative, heavily discharging wound. But I accepted the challenge. So we opened up the wound after 3 days, and we found that the whatever exudate was, it was totally absorbed by the UrgoClean AG, and there was no maceration seen around the wound tissue, and it was little bit fine. So dressing was changed after every third day. After third dressing change, pain and exudate levels were very well decreased, and we saw that the wound was gradually reducing with the development of the granulation, small granulation tissue here about it. After 3 dressing change with UrgoClean AG, the wound appeared clean and with a minimal slough. Patient was followed by negative pressure wound therapy for rapid healing of the wound with a platelet-derived growth factor along with application of Urgo contact layer. We still continued the use of Urgo while doing all these things also, and we found that though the size of the wound has not changed, if you can see, but the wound appearance has changed a lot. I must say UrgoClean definitely reduces the pathway of wound healing. Many times the size of the wound doesn't change, but the wound appears good and it heals fast. So initially it was 5 by 3 by 4, which later on we can see 5 by 1 by 3, and slowly over a period of time, the tissue from unhealthy with slough, which has come to slough which has on a minimal side. Exudator has gone down. Pain has also come down. Frequency we have kept for the every third day only. Cleansing agent we have restricted ourselves for the normal saline only. Dressing Urgo AG. So at the end we can see that from day 1 to day 6, it has been shown that the slough has gone very well down. After 3 dressing changes, the UrgoClean AG pain exudate level had decreased, and the wound bed appeared clean and healthy with less slough. Hence, UrgoClean AG, the wound size had significantly reduced, and we can notice a healthy wound bed with a granulation tissue. The wound was then treated with negative pressure wound therapy, PDGF, along with the application of UrgoTool contact layer. This patient was later treated with negative pressure wound therapy, and I have this last photograph also. The wound has healed completely. So after 6 days of UrgoTool AG, so you can see the approximation of the wound, healthy wound bed, and there is a reduced edema of the patient, swelling, also good approximation. Okay, you can see the wound is healing very well. Okay, though I don't have the right last photo, but whatever the patient I have, the wound has healed completely. So this is a second patient of me. This patient, 39-year-old male patient, he was heavily of chronic tobacco chewer. He had a dry gangrene at the great toe. So when the arterial Doppler was done, it was showing that the vessels were heavily thrombosed. He had to underwent the common iliac artery stenting, followed by amputation of the great toe. So 39-year-old male patient underwent amputation followed by a non-healing wound with a secondary infection of 45 days. The wound was not responding even after amputation of 45 days. So after 45 days, infected wound appeared with a slough and foul-smelling discharge. This patient was referred to our Nasik Diabetic Food Foundation for the further management. Pain score was 4 to 6 with heavy exudate. Peri wound was also macerated. The wound was earlier treated with Usol. The patient used to dip his foot in the Usol solution. I don't know why, but he used to dip this in the Usol solution, and it was treated with Betadine and cotton gauze absorbent dressing on alternate days. After cleaning with the normal saline, when this patient appeared, we clean with the normal saline. We did a minor debridement, removing the slough as much as possible, which is visible. Then this wound was cleaned with and dressed with the UrgoClean AG. Treatment follow-up. Dressing was changed after every third day. This patient had severe pain from the day one, so he was even not allowing for the dressing because it was ischemic pain. But he responded to the UrgoClean AG. The dressing was changed after every third day. After 4 dressing change, pain and exudate level had decreased. The wound bed appeared healthy. The wound started growing, gradually reduced. After 4 dressing change with Urgo AG, the wound appeared clean with a less slough. The patient was followed by PDGF therapy. So here also if you can see, there is a good approximation in the size of the wound. Wound bed has been converted from unhealthy to a less slough. Exudate has gone down from the moderate with a foul order to a moderate and nil foul order. Pain score has gone down from 4 to 6 to 0. Frequency of change of dressing we had kept for every third day only. Cleansing agent or normal saline. Dressing with the UrgoClean AG. So at the end, so from day 1 to day 40, because as the patient was staying apart, very apart from the institute, so once in a week he used to follow up with us. So we found that there is a good healing in the wound. The conclusion and discussion is after 4 dressing change with the UrgoClean AG, pain exudate levels had decreased and the wound bed appeared clean and healthy with less clot. Hence, UrgoClean AG, the wound size had significantly reduced and we can notice a healthy wound bed with the granulation tissue. The wound was later treated with the PDJ therapy along with the application of Urgotool contact layer. This is another patient, third patient. He's 22-year-old male patient, diabetic, post CABG, and he is on alternate day dialysis. He had a cracked wound on his heel, which was followed by the secondary infection at the heel. So debridement was done outside, followed by non-healing wound, and the wound was associated with a severe pain as the Doppler study was showing severe atherosclerotic changes at the local area with a monophasic supply. So this 30 days old infected wound appeared with a slug and foul smelling discharge. Pain score was 8 to 10 with a heavy exudate and their peri-wound maceration was seen. The wound was earlier treated with hydrogen peroxide, betadine, cotton gauze, absorbent dressing and alternate day. So we did a debridement of the wound followed by normal cleaning with the normal saline and UrgoClean application. So during follow-up, we found that with the application of the UrgoClean AG, the pain score of the patient has significantly reduced. The compliance of the patient has improved, and you can see on day 8 there is a maceration, but by 24 there is a good healing of the wound, good healthy granulation seen around the wound. Dressing was changed every third day. After 5 dressing change, pain and exudate level had decreased with the wound bed appeared healthy. Wound size has significantly reduced. After 5 dressing change with the UrgoClean AG, the wound appeared clean with a minimal slug. I must say there is a good approximation in the size of the wound. With the wound bed has come down from unhealthy to less slug, and finally the healthy granulation was seen. Exudate, which has come down from moderate with a foul odor to the moderate. At the last, no exudate. Pain, which satisfied to us from 8 to 10 to 1 to 3. Frequency, we have kept ourselves for every third day. Cleansing agent, we prefer normal saline only with the dressing of UrgoClean AG. So, with the summarize, from day 0 to day 30, the patient has a very good compliance in view that the pain was coming on and he was doing regularly dressing with his family physician. We educated the family physician also how to change the dressing after every day and share the photos. The conclusion is after 5 dressing change with the UrgoClean AG, pain and exudate levels had decreased and the wound bed appeared clean and healthy with a less slump. Hence, the UrgoClean AG wound size had significantly reduced. We can notice a healthy wound bed with the granulation tissue. So at the end, with the conclusion that UrgoClean AG gives a very good option for wound with a slough and biofilm. Biofilm is one of the major factor which cause delayed wound healing, and UrgoClean, with the help of the UrgoClean, we can remove the biofilm as early as possible or effectively. Infection and biofilm are completely cleared. Observe good desloughing properties and wounds are completely clean, managed and reduce the level of exudate, controls the peri-wound maceration and thus help in preventing secondary bacterial infection, improve the healing rate and reduce the wound surface area. It's better than any other standard care of treatment and the patients was getting better. So application of the UrgoClean AG, it is very easy as compared to other dressing methods. So the compliance of the patient definitely improves, and we find the benefit of the patient in the form of good healing of the wound. Thank you very much.
Thank you so much, Dr. Sakin. And I had immediately a question in my head when you were talking, but there's the same question came also from the audience, talking about cost versus cost effectiveness. We saw that your patients were treating their wounds with conventional, very, very cheap dressings, which don't cost very much at all. But changing it every day. And as we see from one of the cases, it was also for 45 days, where rather progress, the patient saw regress of the wound. So talking about cost versus cost effective, because obviously UrgoClean AG would be more expensive than using gauze or cotton wool or whatever. What is your take on that? Do you think that by means of using a more advanced wound care dressing, which costs more, will at the end of the treatment save you at the end money?
I must say, if you ask for the cost factor, definitely UrgoClean is expensive as with the routine dressing, but these patients are having the wound which are not healing since months and months. Okay, and we are giving an effective way or an advanced way to heal the wound fast. Okay, so patient definitely at the initial days they say that the treatment is little bit costlier, but as the wounds start progressing very well and they can see the result also, so this help us to continue the same line of treatment. The results speak that the wound is healing which was not initially there. So cost factor is there, but it is accepted by the patient as the wound gets started healing and showing a good result. So I expect that sooner or later the cost will also come down. So as the treatment gets spread all over to the all physicians and clinicians too. Thank you.
Thank you very much. I would like to put a question to all the three speakers from your experience. In my presentation, which could be seen as a marketing stint, which basically it is, but we're talking about evidence-based practice here. One of my suggestions was that because we're treating the inflammatory process of the wound, you will see the decrease in the signs and symptoms of the inflammatory process, like the reduction of exudate. What is your take from your experiences for all the three presenters? So maybe we can start with you, Dr. Sakin.
There is a good reduction in the size of the wound with the use of the UrgoClean AG, and with a short duration of it's about 30 to 40 days. Okay, and definitely it will shorten the period of the healing, and there is a good healing of the wound. Definitely, it creates a very good result.
Thank you very much, Dr. Venkateshwaran. I hope I pronounced it right this time. Did you see a reduction of the inflammatory process of the wound?
Yeah, so what I could see in terms of in my patients, the inflammatory process is something which was definitely being helped. I wouldn't say I saw a drastic reduction in size, but in terms of the inflammatory processes, as indicated, especially by the the reduction in the pain. Now that is a very important indicator, I think. Like anybody who tells me that progressively every dressing the pain is going on coming down, I am happy with that dressing. So reduction in pain, reduction in peri-wound maceration, redness, the sort of puffy edematous look, all that is very positive signs of combating inflammatory processes. So I'm happy from that point of view. There was a distinct difference. Yes.
Thank you so much. Dr. Jessy, your take, please.
Yes, I would like to say, both my patients per se inflammatory. The pain factor was almost nil because of their neuropathy. But apart from these patients, I have used it on a couple of other patients who were symptomatically painful, especially the heel pressure. So they definitely did get better with the UrgoClean AG dressings. So pain definitely is reduced. The second is in the chronic wound, when the autolytic debridement, which usually happens in the inflammatory phase because of the proteolytic enzymes, that over a period of 6 to 8 months, they start reducing. So that's when we start using it on a chronic wound, it's like kickstarting the inflammatory process which assists in desloughing. When we talk about the acute wound in my patient, he had a severe peripheral vascular disease and it was maintained with collaterals. Per se, the autolytic debridement action must have been there. Urgo must have added to the action. So somewhere in diabetic patients where you expect the first stage of inflammation to be there but not to be there. So Urgo helps in autolytic debridement. So it actually assists the first stage of healing.
Thank you very much. As we know, using a dressing is basically part of the holistic management of the wound. You have to treat the patient and you have to treat the wound together. You don't just treat the wound locally, you have to manage the patient as well. And an interesting question here was, should we supplement the treatment of the local wound with UrgoClean AG, but also supplement it with antibiotics?
Can I answer?
Yes, all three speakers. Yeah, we can start with you, Dr. Jessy.
Yes, I prefer to use antibiotic on my patient till the patient has got systemic symptoms and also their hemogram, the WBC in case it's high or the creatinine. My main marker, and for a patient, the marker it would be appetite. Once the appetite comes back, I feel the patient is improving. I would definitely start them on culture-specific antibiotics, which covers aerobes, anaerobes, and if it's a chronic wound, I do cover the fungal element empirically. And I would like to stop my antibiotic when the wound starts showing improvement locally, and if there is no evidence of spreading infection anymore, and also when the bone starts covering. And take a repeat tissue culture after a couple of weeks of stopping the antibiotics, tissue culture. And in case there is any contamination, I would again go back to some oral antibiotics, or sometimes I do use stimulant in case patient is not tolerating oral antibiotics. And that's how I deal. There is no hard and fast rule or a fixed protocol, but as and when I face difficulty, I switch on and off of antibiotics.
Thank you so much, Dr. Jessy. Dr. Venkateshwaran, what is your take?
Most of us, I think, have roughly similar antibiotic policies. I don't think I differ too much from what Dr. Thomas has said. I believe a lot in giving a lot of local care rather than use more of antibiotics. So my treatment shifts towards antibiotics only if I see something going wrong with the wound, or if there is any red flag in terms of how the wound looks. Yeah. Otherwise, I'm happy with my local care mostly.
Yeah, so basically it's looking at the international guidelines, which suggest that you treat the local infection locally, but then if you have spreading infection, you have to use the antibiotics as well, right?
Yeah, absolutely. Absolutely.
Fantastic. Dr. Sachin?
Yeah, I am very confirmed with Dr. JC. At the initial, we can use the antibiotic at the initial level of the wound. So that will definitely help the UrgoClean to work fast. Okay. Definitely, once the symptoms are gone down, one should stop the antibiotic and let the local treatment go ahead, and definitely it will heal the wound. Many times we have to see the vascularity of the wound also. Sometimes we have to see the monitor the CRP level also. If the CRP levels are initially high, we start the local treatment, start the antibiotics, let the CRP goes down. So we are very sure that the things are working. See, we are not opening the wound for 3 days. Meanwhile, if the patient is continuously throwing the fever and his general condition is not, so you have to sometimes add the antibiotic. It depends patient to patient, okay. But most of the time, at the initial, what I do is that at the initial I start the antibiotic and followed by the local wound care, which is followed.
So we have 3 questions, and I will put one question to each speaker. So the question for you, Dr. Sachin, there is a question like in Fournier's gangrene for in diabetic patients, would you think that UrgoClean AG could be helpful?
Oh, gangrenous patient. Hello.
Fournier.
Hello.
Hello.
Yeah. I have not used.
You did, okay. If any of the speakers can help us here, I think it would have a role if it is not dark necrotic eschar. But if it's fluffy, I think it would. I don't know if the other speakers want to jump in.
I mean, Fournier's gangrene would be probably just like any other necrotizing infection. I guess you have to go in very aggressively and hard with surgical steps first. And then I guess then after that it comes down to managing just like any other sloughy wound. If there is a good amount of slough or biofilm, then again maybe initially we can go in with a more aggressive surgical and local sharp debridements kind of thing, because of the, I think most Fourniers, they are heavily exudating, and they because of the situation in the perineal region. I don't know whether we would really like to use an expensive dressing material which needs to be changed very frequently. So maybe once it becomes moderately exudating and has some slough, maybe then we can switch over to using something like UrgoClean. I think that's my opinion. I have not really used it on a Fournier's case, but I think this would be my take on it.
Thank you very much. There's an interesting comment. I heard from the comments of all the 3 speakers that that where there was pain was reduced. However, there is one of the colleagues who said that he had a patient where there was pain after the application of the dressing. Would you attribute it to the dressing itself or something else? Any of the speakers?
I think it's probably hello.
Yes, go on.
Yeah, I think it probably is something to do with that particular local wound, and maybe some exposed nerve endings of that particular wound. Because, however, I mean, I don't know. I mean, I think I can speak for everybody. I think we have had a pleasant experience as it is with application has never really resulted in pain.
Yeah, thank you. Dr. Jessy, do you want to add to that as well?
Yeah, I do agree. I don't know why there should be pain because of application of UrgoClean AG. I think we'll have to rule out other factors before we blame it on Urgo.
Thank you very much.
I'm not sure if I'm audible or not. Myself, Dr. Anu from Amrita. So I am the one who had put up that question. Okay. So we have actually used UrgoClean for a few patients, not one of the patients. We have used it for at least 20-25 patients in the last 1 month. So it has been a regular complaint from most of the patients that after application of UrgoClean AG, in the initial 2-3 days, they have been having severe pain. Severe pain was there over the wound. But however, after opening the wound is looking healthy, wound is clean, wound is well granulated, and it has completely reduced in size also. So, not like I just wanted to know if it is related to regeneration of the nerves, or if it is related to something else, because it has been we have been noticing in a few patients. So we were not sure as to what is the cause of that. But however, our application of UrgoClean has definitely given us a upper hand. It has actually improved all our wounds. I would actually like to share some photos also. We have used in few cases. It has shown that it is well granulated. But this is just my question, sir. Not sure as to why it is happening. So because I've heard a few speakers saying that pain is actually reduced. So that is why I just wanted to ask that question.
Yeah, it is very interesting because even from the German observational study, which was over 2,000 patients, pain was one of the issues, and I was actually going to ask the clinicians as well about the health-related quality of life of the patients, if they think it actually enhances the health-related quality of life of the patients. Probably if you have a case or two or some cases which had been painful, I'm sure that the team on the boots on the ground will be able to assess the particular patient and check, because it seems it was some particular patients. I don't know if that is the case.
Was it all diabetic food? Sorry.
I think it was different type of patients, Dr. Jessy.
Sorry.
Yeah. So what is your take as all the three speakers? How would you consider, and we'll take this as the last question because unfortunately we are running out of time. What is your take on the improvement of the health-related quality of life of the patient, and what would be a simple take-home message from your side? So you are on the screen, Dr. Vedat. Sorry, doctor. So you can give us your take.
You know, it's simple. Just call me Venkat.
Okay, Venkat is good. Okay, so your take-home message and the health-related quality of life.
Yeah, so I feel there is a definite improvement in the health-related quality of life, because quality of life is a factor which, you know, definitely the number of dressing changes and the kind of comfort associated with the dressing changes, you know, matters a lot. So I think in terms of painless and a very simple to an effective tool, it definitely goes quite far in improving the health related quality of life. This is my take.
Thank you very much.
I have had a good experience in terms of pain reduction. So I have, frankly, I'm quite surprised knowing that it can actually increase pain. But I feel it is definitely, it actually improves the quality of life, definitely.
Thank you very much. So in those cases, we promise that we will investigate and we will follow up with the specific clinician if he gives us his data that we can follow up.
Maybe something to do with, you know, we can maybe we can make inquiries into the method of dressing, and, you know, maybe they do a little bit of debridement at the time of dressing, something that could be irritating the nerves, and anything is possible.
Yeah. Thank you so very much. Dr. Jessy, your message about the health-related quality of life and the take-home messages to the attendees.
Regarding, I mostly treat diabetic foot ulcers and a few of venous ulcers also. So most of my patients, especially during COVID time, and since it was launched during COVID time, UrgoClean AG did improve quality of life, in the sense, otherwise if the patient had to come repeatedly to me for dressings where I do little bit of sharp debridement in OPD, since patient could not access hospital or doctors in these difficult times. UrgoClean AG was a blessing, because these dressings were easily applied by their relatives or their home care nurses at home, and the same effect was they could get the same effect by not visiting a doctor or a hospital. And so I think we need something like this, where patients can manage their dressings at home, especially in Bombay, where we stay in high-rise buildings. where they need help to come to a hospital. They need some vehicle to come to a hospital. All these were the difficulties what we faced during COVID times. I think a lot of patients did feel good about the fact that they had a UV dressing and a very good outcome. And
Thank you very much. Thank you, Dr. Jessy. Dr. Sachin, if you can give your take-home message, please.
Yes, when you talk about the diabetic wound, everybody knows that either they don't heal or they take a longer time to heal. So, and these patients, they do require a regular hospitalization, application of the variety of gels, using of higher antibiotics, and with the help of the UrgoClean agent. Definitely, we saw that the hospitalization has gone down. Okay, and every with change of every dressing, we saw there is an improvement in the part of the wound. Definitely, he's healing the wound fast, and the compliance and the health quality of the patient improves a lot, and the wound ultimately heals well.
Thank you very much, doctors, for sharing your experiences. This is the end of the session from the clinical point of view. However, I would like to pass on now the speaking to to Mr. Amarcha to give the end message for the session. Thank you very much.
Okay, thank you, Emilio. I'm Ramhasha. I'm the sales manager for this UCAR Urgo. I really, first of all, extend my thanks to each and every participants as well as the speakers for spending some time on the clinical cases as well as sharing your experience with the peer group so that the benefits can be passed on to them so that more and more patients can be really benefit out of that. So I can able to really see that the conviction of almost all the cases or all the patients which you just seen that. Thanks for the technology. And I can also see that the pain-free and atraumatic removal, which is really a very innovative thing which can able to see from this technology. I thank each of the speakers for really taking an interest and spending some time and interacting with our team members to just to come and show your interest towards this product. And you also got a very good success. That's what I can able to see from them. And I should also thank my marketing colleagues as well as my entire sales team who has really taken their efforts at this even COVID time also to reach you, to support you. And at the same time, we launched the product successfully in the market in the month of October. Believe me, sir, I think the response was really, really good. In fact, the doctors, whomever the doctors who has tried this product, they really said that I think this is the product which we are looking all these days. So I'm really happy to share that successes with you and many more to come. I think together, let us join together to improve the quality of the life of the patient so that definitely they will thank us back so that that is a big reward for you as well as to us. So thank you once again for the wonderful evening and also for the content of the meeting. Thank you.
Thank you. I think we can close the show. Emilio, thank you everyone for your participation and to all the speakers for sharing your candid feedback. Thanks a lot.